Okay, now it's time to go on to phase 3 of hemostasis, and that's the coagulation phase. Now, this is certainly going to be another part of hemostasis where we're going to see amplification, in other words, positive feedback. And the positive feedback is going to come in the form of, ultimately, thrombin feeding back to activate more platelets, which of course will lead to more clotting factors, which will lead to more clot and thrombin synthesis, and again, going back to increase the number of activated platelets. So the end result that we want is a thrombus or a clot. Now the actual clot is made up of fibrin threads, and I'm going to show you a picture of that very soon. So there are 12 clotting factors numbered 1 through 13. Number 6 was a redundant discovery, and therefore it does not exist. One of the clotting factors is actually a cofactor called calcium, and calcium is factor 4. Most of these factors are synthesized in the liver, and they are synthesized as an inactive enzyme. When an enzyme is made in an inactive form, we say that it is a zymogen or a proenzyme. And usually the enzymes that are made in this way will have a prefix of pro, or they will have a suffix. That means their name will end in ogen. When they're activated, then they drop either the pro or the ogen part. For example, factor 2 is prothrombin. When it's activated, we just call it thrombin. Factor 1 is called fibrinogen, and when it's activated, we just call it fibrin. There are 4 clotting factors that require vitamin K in order to be synthesized correctly. Those 4 clotting factors are 2, 7, 9, and 10, and it is very important that you remember those. So it is not so much important to me that you memorize the proper term for all of these clotting factors, but I do want you to know clotting factors 1 through 4 by their name and their number. When you get to clotting factors 6 doesn't exist, 5, 7, 8, 9, 10, 11, and 12, and 13, I just want you to know them as their Roman numerals. So I remember this with the little mnemonic that's shown on the screen here. Future physiologists take fun classes for 5 to 13 years. And that's underneath the words for factor 7, so I apologize for that. So factor 1 is fibrinogen. That represents the F for future. Physiologists stands for prothrombin. Take fun represents tissue factor, or factor 3. Classes represents calcium, factor 4, and then 5 to 13 years is just to remind you that it's the Roman numerals for factors 5, 7, 8, 9, 10, 11, 12, and 13. I'd like to just remind you about tissue factor, or factor 3. There are 2 different places that factor 3 is going to be made and released from. And factor 3 can either come from platelets or it can actually come from damaged tissue. When factor 3 is from the tissue, we say it's tissue factor or tissue thromboplastin. When it's from the platelets, we call it platelet factor 3. I'm just going to call it factor 3, and I don't want you to stress over which specific type it is, if it's coming from the tissue or the platelet. I just call it factor 3. Okay, so we're still in the coagulation phase or clot formation, and this picture is showing you the actual fibrin threads. And that's the actual clot. You'll notice that red blood cells are trapped or embedded within these fibers, but they are not active participants in the clot formation. They simply were there in the wrong place at the wrong time when these fibrin threads were being synthesized. So clotting can begin within 15 seconds after damage to blood or a vessel or tissue occurs, and it's a series of steps. Ultimately, we want the conversion of fibrinogen, which is a circulating plasma protein, to be turned into its active fibrin threads. So these fibrin threads are going to cover the surface of the platelet plug, It will trap red blood cells within the fibrin threads, but again, those red blood cells are not active participants of the clot formation. The actual blood clot that forms, or thrombus, is basically going to seal off the damaged vessel wall. There are two clotting pathways. There's the extrinsic pathway and the intrinsic pathway, but they both will converge on what's called the final common pathway. I do not want you to memorize the specific steps of the extrinsic pathway nor the intrinsic. What I do want you to know is that the extrinsic pathway is triggered by damage outside of the bloodstream. And when this pathway is provoked, it's going to begin with the release of tissue factor. Again, that's factor 3. And this is a lipoprotein and phospholipid kind of substance. The intrinsic pathway is going to be triggered by damage to the blood or blood vessel itself. Now, this is going to lead to the release of platelet factor 3. Again, it's still factor 3. It too is a phospholipid that's released from the platelet cell membrane. Now, let's continue with that idea. If someone were having open heart surgery and on a heart-lung bypass machine, their blood would be redirected through a series of glass tubings or plastic tubings. Now, would you want their blood coming into contact with this smooth glass? Now, it's smooth, but it still is going to trigger the activation of platelets. Would you want them to start the intrinsic pathway? You wouldn't, because then the patient's blood would coagulate inside that tubing. So the patient and the tubing is going to be treated with heparin, and the patient will also have heparin in his or her blood. And the heparin is going to inhibit this intrinsic pathway and prevent clotting. I will talk about heparin more in just a little bit. You don't have just the extrinsic pathway or just the intrinsic pathway. The two will begin together. The extrinsic pathway is faster to begin, but develops less prothrombin activating substance, abbreviated here as PAS. That is the beginning of the final common pathway. The intrinsic pathway is somewhat slower by just a few seconds, but it will develop much more prothrombin activating substance. So that's what I want you to know for the extrinsic versus intrinsic pathways. Extrinsic is faster but produces less PAS. The intrinsic pathway is slower but will make more PAS. Now, on this slide, you should start to appreciate the fact that I'm not making you memorize all of the individual steps for the intrinsic pathway, nor the individual steps for the extrinsic pathway. So what I want you to realize here, if you look at the cascade of events that is required for the intrinsic pathway, you basically need the blood vessel to be damaged, exposure of collagen, and I'll remind you from class time that once the collagen fibers are exposed, the von Willebrand factor can bind to collagen and then cause aggregation of the platelets. And you'll notice that this is going to activate factor 12, and then active factor 12 is shown here as the X with the two lines with the little subscript A. Active 12 will activate 11, which then activates 9, which then combines with platelet factor 3 to form active factor 8. I mean, that took me a long time to go through that. So the intrinsic pathway takes a longer time to make prothrombin activating substance because all these different factors have to be activated. The extrinsic pathway is requiring fewer activation of clotting factors and therefore is faster, but it will make less prothrombin activating substance. Now, what exactly is prothrombin activating substance? It is the beginning of the final common pathway. It is a complex of proteins and calcium. Specifically, it's factor 10, factor 5, factor 3, and factor 4, which is, of course, calcium. When you have all of those things assembled together, then you have made PAS. And the prothrombin activator substance, its name tells you what it's going to do, is going to activate prothrombin, turn it into thrombin. Now, if you're looking at the bottom of the screen, you'll notice that thrombin is going to activate fibrinogen into fibrin. It will also activate factor 13 into an active factor 13. The fibrin threads require factor 13 so that they will become covalently linked, stabilized as fibrin threads. This is finally a stable clot. So let's do it again. What is the final common pathway? It begins with the synthesis of prothrombin activator substance, factor 10, 5, 4, and 3, which can then activate prothrombin into thrombin, which then activates fibrinogen into fibrin, and then those fibrin monomers are going to be cross-linked together by active factor 13, the fibrin stabilizing factor. Now I remember this entire pathway like this. If 10 plus 5 plus 4 and 3 equals 22, then 1 plus 13 equals glue. Now, it's true 10, 5, 4, and 3 does equal 22. But in my little rhyme, I emphasize the word 2, which is to say that prothrombin activator substance is going to activate factor 2, which is prothrombin, into active thrombin. Factor 1 is fibrinogen, and factor 13 is the fibrin stabilizing factor that cross-links the fibrin threads. That's what I mean by making glue, meaning the stable clot. Now, what exactly does fibrinogen look like that it has to be activated and cross-linked? Well, fibrinogen, I'll remind you, is a plasma protein. It's always present in the plasma. And you wouldn't want it to be aberrantly activated and have these fibrin threads synthesized inside your bloodstream. So, when prothrombin, factor 2, is activated into thrombin, it's going to cut off these little caps on the ends of fibrinogen, shown here in the middle of the screen with the box around them. And you'll see that I have written thrombin chops these ends off. If you follow the arrow down, you'll see what remains are just fibrin threads. And they have a charge associated with one side, negative charge, and on the other side would be a positive charge. So these fibrin threads are going to align with the positive sides being attracted to the negative sides, as shown here in the very bottom picture. And they're going to link up like that, or align, I should say, that way. But shown here in red are the covalent links that factor 13 will make, the covalent bonds. This stabilizes the fibrin threads in this orientation. We finally now have a clot. Now, phase 4 is clot retraction. Once we had the fibrin meshwork, we're going to have clot retraction, and this happens within 30 to 60 minutes of injury. So the platelets, remember, are going to release actin and myosin. And actin and myosin, if you remember from muscle contraction, can interact with each other. And when they interact with each other in muscle, this is basically going to cause the muscle fiber to shorten. Well, actin and myosin can also interact in a clot and actually pull the torn edges of a vessel closer together. This is going to help reduce the amount of residual bleeding and stabilizes the injury site. Now, this is also going to make it easier for the fibroblasts to repair the endothelial, let me start that over. This is going to make it easier for the fibroblasts to help repair the smooth muscle cells and the endothelial cells and even the collagen fibers that are found in the basement membrane of the blood vessel. And lastly, this brings us to fibrinolysis, or clot dissolution. Once the blood vessel or tissue have been repaired, the clot is no longer needed. Now it needs to be basically removed, scrapped for parts. Now, plasminogen is a plasma protein. It's found in your plasma all the time. It's a circulating globulin. When it's activated, again, it's a zymogen, so we're going to drop that suffix of ogen. It'll turn into plasmin. This is the clot buster. It actually breaks down those fibrin threads. It's a proteolytic enzyme. What that means is it's an enzyme that chews up, hydrolyzes other proteins. It's very similar to trypsin, a proteolytic enzyme that your pancreas releases for you to digest proteins that you've eaten. So this plasmin, the clot buster, is going to hydrolyze the fibrin threads. This is significant because it means that once those micro tears in our blood vessels have been repaired, now those tiny little clots can be removed. But there's an issue here. Plasminogen needs to be activated. Again, it needs to drop that ogen part, right? So what's the plasminogen activator? Tissue plasminogen activator, or TPA. Now this is oftentimes referred to in the clinical setting as the clot buster, but it's not. It is not the clot buster. It does not chew up the fibrin threads. It activates the clot buster, plasminogen, and turns it into plasmin. If someone actually has a thrombus, say a pulmonary embolism, where a clot has dislodged and has now become trapped in the very small pulmonary capillary beds, the person has about an hour for them to receive tissue plasminogen activator substance. There can even be a person who can throw a clot, say, in the coronary arteries. Basically, we say that there is a golden hour. That is roughly the amount of time that the physician, surgeon has to get the tissue plasminogen as close to the clot as possible. They actually might insert a very small little tube through someone's veins to get to a heart artery or pulmonary artery. Anyway, they can actually feed this capillary tube through a large vein in the body to ultimately get to a different destination in the patient's body to deliver this tissue plasminogen activator substance. There, it will activate the local plasminogen into plasmin. This TPA, though, is very, very expensive, and so we do have cheaper alternatives. It was discovered that urokinase, an enzyme found in urine, could also activate plasminogen into plasmin. We've also discovered that there are bacterial proteins that can do the same thing, like streptokinase. But we can't use this too often because it is from bacteria, and with frequent exposure is going to provoke an immune response from a person's body because it will have a bacterial antigen type tag to it. And finally, you should be seeing here at the bottom of the screen that thrombin, active factor 2, which leads to the fibrin clot itself, also activates plasminogen into plasmin. Finally, we're starting to see negative feedback because when thrombin activates plasmin, of course it's going to be hydrolyzing those fibrin threads. Finally, we're going to get a stopping mechanism to that clotting pathway. Okay, this concludes this segment of your hemostasis lecture.